Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to this special edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community, with our goal to spark conversation, ideas, and action. Since we are live, I want to remind everyone that while we don't take questions over the line, you all have the opportunity to type your questions into the question box at any time. I will check for the questions throughout the session and present them to the speakers at the very end. Go ahead and put them in, though, as you think of them. We're joined today by colleagues from Children's Hospital of Eastern Ontario and the BC Children's Hospital for this timely webinar, Establishing and Managing COVID-19 Command Centres in Hospitals Serving Children and Youth. Managing a complex and fast-moving crisis like COVID can be extremely challenging for hospitals serving children and youth. Today's webinar is brought to you with support from HIROC, the Healthcare Insurance Reciprocal of Canada. I'm pleased to welcome Trevor Hall, Vice President, Healthcare Safety and Risk Management, who would like to welcome you all. Thank you, Trevor.
Hello, everyone. My name is Trevor Hall, and I am the Vice President of Safety and Risk at HIROC, which is the Healthcare Insurance Reciprocal of Canada. And I sincerely wanted to say hello, but also really wanted to thank you for all that you're doing and your dedicated teams that are doing to keep us moving during this crisis. And everyone at HIROC truly appreciates you and your teams. We at HIROC are here for you, and if HIROC subscribers have any questions regarding coverage or needs around safety or risk, please feel free to reach out to us or myself at any point in time. Enjoy the webinar, and thank you again for everything that you do.
Trevor. As well, I'm delighted to welcome our speakers today. Dr. Peter Skippen, Pediatric Critical Care Physician and Clinical Investigator of the Division of Pediatric Critical Care at BC Children's Hospital. Dr. Nisha Thampi, Associate Professor and Pediatric Infectious Disease Consultant at Children's Hospital of Eastern Ontario, or CHEO. And Dr. Lindy Sampson, Chief of Staff and Chief Medical Officer of Children's Hospital of Eastern Ontario and Clinical Investigator at the CHEO Research Institute. For those of you on Twitter, please tag us at Child Health Can to any webinar-related tweets and go ahead and share away. And it's now my pleasure to pass the mic to Peter.
Hello, everyone. Pleasure to be here. Thanks for inviting me. So I've just made a few notes here about our process that's got us to where we are today with this COVID-19 pandemic. It first hit me Thursday 2 weeks ago when my spring break was cancelled and all non-essential out of Canada travel was discouraged or cancelled. So then I arrived at work on the Monday after that, which was 10 days ago. Our EOC had been established, which introduced a new reporting structure for all of us. We'd talked about the EOC and practiced it, but we'd never actually been in a real situation. And at that time, from the medical perspective, some of us presumed from the literature that this was not really a pediatric disease, but that we still had to plan for it and prepare for the worst case scenario, which is what unfolded. That same morning that the EOC became operational, Ministry of Health started expanding their role and dictated to us that all elective surgery would be cancelled from that day onwards. So the first step, I guess, for our hospital was to expand our potential capacity. So hospital occupancy was reduced. We expanded the capability of our PICU. We'd already worked on that the week before with, in anticipation. Messaging started going out from the hospital and elsewhere to discourage visits to the emergency department and the wards. We reached out to our other health authorities offering assistance, potentially diverting pediatric patients from the other health authorities, and offering to accept adult patients to our pediatric intensive care unit. We had already taken inventories of our ventilators, renal replacement therapy machines, and other equipment. As mentioned, surgery was curtailed. We have 3 pods in our PICU, 2 of which are functional. A third is sort of for surge capacity. They're all made functional and ready to take patients, adult or pediatric. We separated 2 of our pods into a clean and a droplet to take the infectious patients in one and keep our other cases, which is typically our cardiac ICU, but that became more of a general ICU. We enhanced our pediatric medical coverage to protect the 2-pod system. We updated our Code Orange policy and PAN Atlas for RTs, RNs, and MDs. The Department of Pediatrics and the rest of the hospital, surgery and anesthesia, started exploring potential for retirees to come and help should the influx occur. One of the overall principles, I guess, of the practices that we were implementing was to keep COVID out of the hospital. So hospital went on to a phased lockdown with card access for staff only. All entrances were staff and screening implemented. Limited family access and patient access. So currently, that's still an evolving process for how many visitors can come and see the kids. Staff basically are mostly working from home. Clinics are closing. So trying to move to a virtual health system, that's put enormous strains on the internet networks, as I'm sure you're all experiencing. So, but the 2 systems that we're scrambling to try and implement are Zoom and Skype for Business. Zoom for Business as well. That's obviously IMIT is overwhelmed as well, but everyone's doing their best. From a communication perspective, we've had daily meetings with our CMO, Chief Medical Officer, and EPOC operations lead with the medical staff. I've been involved with daily provincial critical care meetings with the other adult units. There's been daily debriefs for the PICU team every morning after the EPOC to update them on any new news and concerns for the ICU specifically. There's been daily walk-arounds in the PICU with the medical director and the nursing leadership to support staff and answer any questions and concerns. There's been increased nursing leadership availability, 24 hours around the clock to answer any concerns and deal with issues as they arise in real time. From a clinical preparation perspective, we've been doing daily simulations, trying to finalize an intubation process. Donning and doffing, obviously, is a huge thing. Supplies of personal protective equipment is obviously a nationwide huge thing. Assuming transport of patients from the OR and the ED to the PICU and in between. We did talk about initiating a intubation team, hospital intubation team. That hasn't quite eventuated like it has in and been offered in many of the adult hospitals, but we are working closely with anesthesia to try and standardize our processes. We are developing our own intubation protocol. We've developed our own cardiac arrest protocol, which does diverge from the adult protocols to some degree or to quite a degree, which is where some of the tension that I'll mention shortly is arising. Transportation of patients around the province has also become a problem because we coordinate the transports of these children, critically ill children and others. And a lot of the reason has been the concern of the pilots and the transport team about their risks. And of course, kids often get respiratory diseases, and now we can't exclude COVID until they get tested. So the turnaround time for our transports is becoming very, very long, putting the kids at risk in the community. And as I'm sure you're all aware, we all have very large provinces. So some of the kids in the more remote places can take a 2 to 3 hour plane ride to start with for the team to get up there and then back, and then all the stuff that goes on in between. So our transport team is switching to BiPAP for respiratory support. Whereas previously it might have been high flow, nasal cannula. So these issues are still being resolved, and then they have to clean the plane, which increases the turnaround time. So if you were to ask me what would be the issues and controversies, obviously the big one is PPO, not just PPE availability, but the fact that every regional health authority in this province seems to want to go it alone and do their own thing. And regardless of what the infection control experts are advising. So we in the pediatric world are trying to be a little bit more pragmatic and follow those guidelines. But as I'm sure some of you have seen, some people are wearing PAPRs, and the full Ebola setup that we practiced a number of years ago when the Ebola concern was raised. And so there's so much managing anxiety of the staff, medical and non-medical. We've had theft of our PPE even in the hospital, and it's likely, I won't say to point fingers, but it's likely not just outside of hospital people coming in and stealing. Consistent infection control messaging is a challenge because it seems to change day by day, which is a huge challenge for the public health authorities. When one health authority announces a new policy escalating the amounts of PPE that people are requiring in the time when we're running out of PPE. So it really is a contradiction of logic. Classification of code blue responses. The adults and pediatric, our approach is very divergent from the adult proposed guidelines that they are submitting for ACLS. Allowing mildly symptomatic families at the bedside. That's been a big concern for us because we don't know whether they're not getting tested because we don't have enough testing kits. So we don't know whether they've got COVID or not, and likely don't. But staff anxiety sort of makes us wonder how we're going to deal with that. So the ongoing tensions, I guess, for us would be the differences between the different health authorities, family visitation, the contrast between the adult and the pediatric approaches to some of these aerosolizing procedures, and even within one's own group, there are differences in opinion about how we can manage these patients. So I'll stop there, and if there's any questions, I can try and answer them later. Hello, anyone there?
Thank you, Peter. Over to Nisha and Lindy.
Hi, I'm Nisha Thampi. I'm the Medical Director of Infection Prevention and Control at CHEO. I'll be talking about the early period prior to the full activation of our IMS structure. I'll take you back to January, where we were all hearing reports early on of a respiratory infection affecting individuals who had frequented a seafood market in Wuhan, and the discovery of a novel coronavirus. And we started to pay closer attention at CHEO with reports of human-to-human transmission and spread in the community among those who had not frequented the market and who had not come into contact with cases. And by the end of the month, we gained enough insight from epidemiologists, virologists, math modelers, travel medicine experts, and seasoned infectious disease colleagues who had lived and worked through SARS in Toronto. And it became clear that we needed to prepare to care for children who were exposed or infected with the novel coronavirus, or SARS-CoV-2, which causes COVID disease. We implemented an incident management structure on January 27th, right after the first case in Toronto. And that was to prepare to see pediatric patients, to protect our staff, recognizing from early reports the disproportionate burden of disease among adults, and to plan for an outbreak either in our organization or in our city or more broadly. So the goal of the IMS back in end of January was the coordination of all additional activities and preparations required in parallel with our normal busy operations during peak season period, which is significant in a pediatric organization, and to align ourselves with our partner organizations, including regional hospitals and Ottawa Public Health. Our central committee was meeting every 1 to 3 days, and our preparedness really centered around 3 clinical activities. One was early identification of suspect cases, and then 2 was prompt and appropriate isolation of suspect cases, and 3 was safe provision of clinical care, including staff protection. And so I'll spend the next bit of time diving into these. So in terms of early identification of suspect cases, this involved doing active screening at the emergency department's triage, and we were able to leverage our electronic health record to standardize the screening process. But as everyone is probably aware, we also had to be nimble with the expanding case definition related to the travel history. And so our initial focus was screening at the emergency triage, and then within a few weeks, we had active screening in the ambulatory care and other outpatient settings, so including medical imaging and daycare surgery. And then more recently, we've implemented active screening of patients and staff. Early identification is also predicated on capacity to test patients and identify them as having COVID-19 infection. So in terms of increasing our testing capacity in the last month or in the last few weeks, it's been through the community setting, in assessment centers, and at CHEO for admitted patients, and among healthcare workers most recently. Prompt and appropriate isolation was related to, so initially in Ontario, everyone who was admitted with suspected COVID-19 had to be placed under airborne and droplet contact precautions. And so very quickly, there was the question, we recognized the challenge of lack of availability of airborne infection isolation rooms, and had to create a backup plan for these rooms if these rooms were not available. We were able to purchase a mobile anti-room, and we had a couple of HEPA filters, mobile HEPA filters so that we would be able to create an anti-room and a negative pressure room within a few hours. With the change in provincial guidance from everyone who needed routine care requiring airborne precautions and droplet contact precautions to now everyone requiring droplet contact precautions for routine care, that has helped to alleviate some of the challenges around airborne precautions, but this was part of our early strategy. The safe provision of clinical care really included staff protection, again, because of the recognition that adults have been getting disproportionately affected by the COVID disease. And so we've had a very active clinical care working group that started up at the end of January, early February, to develop clinical protocols in our PICU, to which Peter described in his setting, similar to at CHEO, in our NICU, in our transport service to the region, as well as inpatient medicine and the emergency department. We've provided interim infection control guidance, informed by provincial, national, and regional knowledge. And we initially had a travel screening tool, which is now a moot point. But really, the focus of our safe provision has been to secure enough supply, which Peter alluded to, supply of masks and control of masks in order to preserve them for patients who, for whom we would be very concerned about COVID-19. We have also been doing support at the elbows with education and reinforcement of routine practices and additional precautions. As an infection control professional, I would have hoped that everyone would feel comfortable with droplet contact precautions, but there is recognition that with a novel pathogen, there may be some anxiety around personal protection. And so we've been giving support at the elbows, as well as doing a number of simulation exercises in different units. And that has been championed by individuals within the divisions or departments. So, for example, our anesthesia group has discovered and valued personal protective equipment in the last few weeks, and has really been galvanized to become comfortable around the use of gowns, gloves, face masks, and N95 masks with visors. So that's been really a remarkable effort. We've also been providing more clarity around aerosol generating medical procedures that would require airborne precautions. And then we started to look as a health system at our clinical workflow, recognizing that the burden of pediatric clinical activity will be in the emergency department, in the inpatient medicine unit with patients who have suspected COVID-19, and some pressures in our intensive care unit. And then finally, we've been, in the last 2 months, really trying to streamline our communication with staff, regional partners, families, our governors, and our unions to ensure that we are sharing all our knowledge and work, and recognizing that anxiety often can come from a lack of awareness that the organization is prepared. So ensuring that we not only share our knowledge, but that we be available to take people's questions and concerns. So through virtual questions and answer periods, and in-person Q&As before we implemented social distancing. I'll let Lindy speak more to the last couple of weeks since we had our first case in Ottawa on March 11th, which really changed our approach.
Okay, great. Can people hear me?
Yes.
Hi, can people hear me? Great, thanks. Good afternoon, everyone. I know we're all really busy, and so it's a pleasure to be able to speak with you briefly this afternoon. And you know, Peter and Nisha have really summed up a lot of what's been going on, I'm sure, in many places very well. I'll maybe have 7 or 8 points just to sort of put out there that we've been thinking about or challenging or have challenged us from an organizational perspective. And maybe one is just the acknowledgement that this is a rapidly evolving and ever-changing situation, and what was known or said 1 week or 1 day ago may be different the next. And so a key focus for us is really preparing people across our organization and within the community for that, to be prepared for that, and really emphasizing that just because decisions are being changed or evolved, that it doesn't mean that what was happening before was incorrect. So because of that, we need to be nimble, we need to be responsive, and we need to have good situational awareness of how people are doing and feeling about things. Likewise, a key focus is that because of this ever-evolving situation, planning and implementation decisions really need to be principle-based. And of course, we need to use planning assumptions to know where we're heading, but an acknowledgement right up front that any planning assumptions that we're going to use are going to be incorrect because this is such a new situation that we find ourselves in. So that's one point. The second is, Nisha really nicely summed up the sort of preparing and planning phase over the last sort of 6 weeks, which then switched into an implementation phase, as Nisha alluded to, as soon as we had our first case in the city. And that is, I find, having been through this a time before in 2009, although it's very, very different, always a time of tension because all of a sudden all parts of the organization are touched. So before that, we had a key core group that was right on top of everything, really working very, very hard to get us prepared. And then all of a sudden, everybody came to the table. And so that's always a time when you need to rethink your structures. Do you have the right people at the table for the next piece of work that needs to be done? And a big, I think, decision point for all organizations is, do we have continuation of operations through the IMS IMT structure? That's our incident command structure, because every part of the organization is touched and it really is a new reality. Or do you keep a continuing operations side separate and then make sure the two are collaborating and aligning? And what we chose to do here was really put everything under the IMS structure for this initial acute period of time, and we'll reevaluate that as we move forward. As we keep reminding everyone and reminding ourselves, this is going to be a marathon, not a sprint. And if we do successfully in Canada or in our provinces or specific regions of our provinces manage to flatten the curve at all, then this will hopefully not overwhelm us, but will certainly go on for an extended period of time. So we really need, with that in mind, to be planning for the long haul. And so what we've spent much of the last few days doing, realizing that, everyone's already very tired. There was a huge amount of energy, but people have been working 7 days a week for a few weeks already. And so we have to build in some not redundancy, but some buffer into the structures that we have that are going now. So, bringing on a second person into each of the roles or a co-lead into each of the roles, allowing them to learn the roles so that we can start very quickly switching people out so they can have a day of rest and come back refreshed and stay at it again. A couple of other key areas of focus for us are really on proactively looking at wellness and support issues for all our staff and medical staff. And I'll talk about families in a moment because they're also very important as well. But really focusing proactively on how we're going to support our staff and medical staff. We have to acknowledge and understand the fear that a lot of our staff and medical staff have. Also remind them of their obligations, especially as the healthcare workers, to step up and step forward during these public health emergencies, which, I should have started by saying this. It's really a moment for us here, to feel really proud of every single person that comes into our organization. I'm sure you're all feeling the same way as well every single day, because people really are just pulling together as one team and asking how they can help and looking what they need to have to do. So with the wellness and support in mind, things like virtual drop-ins to support people. We've just made coffee and tea available free for everybody in a physically distanced kind of way. Decisions to sort of offer free parking, especially offer parking to those that need to come into the building that might not have had parking before. Parking's a really big challenge for us in usual times. So those are just little things to look at. But as this evolves, really understanding, especially in those areas that are providing acute care that are more clinically involved, how are we going to support them in the moment? So for example, we have had a few suspected patients come in quite unwell. They've ended up being negative, but have had to sort of ramp up the team and make sure everything was being done. So having a good debrief after each of those interactions to ensure, one, what lessons learned are there, and two, how can we support the team and how is the team doing, and really to to offer them kudos and congratulations for the good work that they've done. And lots more to come on that from our perspective, but just a real understanding that we have to be proactive in our thinking. Likewise, support to the patients that are here for non-COVID conditions, but are watching us as we change everything that we do, and to their families. And so access to information, the free coffee and tea, also being offered to the children, youth, and families that are here, as well as parking, etc., and keeping those inpatients that are here for a long term up to date around what is going on. And there's always more that we can do in that regard. We have, for the very first time here, have 3 family advisors that are our partners through our Child, Youth, and Family Partnership Initiative that have joined our incident management team. And that's the very first time we've done that, and it's working so well. And so we're getting immediate input from families that are actively receiving our care about how we're doing and how we should move forward in our planning. And so that's a really exciting and new thing that we're doing, and it seems to be going very well. I think just a couple of other points just to highlight. One is around the very important piece of sending out communication to everybody that works here in real time every day, and getting the right level of messaging, not too detailed, not too high level. People need to feel that we're being transparent. They need to understand, we know, what we know and what we don't know, and what the direction is for them to do on any given day. People should know what they need to do on that day when they come to work, so they feel safe at work. The other is something that we've really done, and other organizations may be well ahead of us on this, but a rapid switch from in-person visits for non-essential care to virtual care. And we did that almost overnight. It was sort of a planned 2-year project for us, and now it's going to be done within 3 months. But switching to telephone first, and then video, and then integrating that video into our electronic health record has been a real focus over the last week, and it's still some work to be done, and we're slowly bringing on all our providers. And likewise, a challenge in determining in the pediatric world what is considered elective surgery and what is not elective surgery, because we've rapidly been told and directed by the province to ramp down elective surgery. So for children and their families that have been waiting for neurosurgical or cardiac procedures that really don't need to be done now, but it's really hard to defer those. We've also really trying to keep the building, not having people coming to work if they're at all unwell, so implemented an online-based screening tool that people can do from their phones before they come to work, to say they're either good to come into the building or not, and showing that as they enter into the building to a screener with clear direction if they fail the screen, what they need to do. And here in Ottawa, we have a community treatment and assessment center, community testing and assessment center that is streamlining healthcare providers. So that's working very well. I think I'm going to stop there. Those were sort of some high-level points, but very pleased to answer questions along with Peter and Nisha.
Thank you all. This is very important information that people are thirsty for, and the number of questions we've gotten certainly suggests that. I'll start with a few questions. One is, we learned last week of significant severe challenges from our peers in the U.S. hospitals, U.S. children's hospitals, that they're having difficulty with the availability of personal protective equipment. Do you have specific strategies in place to lock down the supplies? Peter, you alluded to some going out the door from external, but potentially internal folks. Have you had what have you done to lock down the supplies or ration the PPEs when necessary?
Yeah, so there's enhanced security. There's more staff being secured for the site. And the procurement is obviously in the hands of the logistics box of the EOC. So the whole EOC has done a great job, and as has already been alluded to, working extended over and above the call of duty. But we don't have anyone manning security cameras, for example, continuously. So, but as I mentioned earlier, there's only 2 or 3 entrances that anyone can get into the hospital now. So they're locked, and with security pass, like ID for staff and stuff, can access, only limited access as well. So there's no magic cure, but that's what we've done.
Thank you. And Lindy or Nisha?
Nisha, do you want to go ahead?
So in terms of our, sorry, could I have the question repeated?
Sure. What have you done? What specific strategies have you put in place to make sure that the PPs don't walk out the door or are rationed when necessary?
Yes. So in terms of our N95s, very early on, we recognized that our supply was walking off the units, so to speak. So for one thing, we took them all back, all out of the tube-in system. We had them centralized, and then we had them available on the units, but through a manager, and it was always available if it was asked for, and if it was appropriate use for that patient encounter.
Of course. Thank you. There's another question. Are any of the guests taking extraordinary measures to remove or limit the exposure of COVID positive or assumed patients to healthcare providers who might be at higher risk, or are older, or those with compromised immune systems?
This is Lindy here. Can you hear me?
Yes, we can.
So this is that's a great question, and one that came to the fore fairly early on. What we have done internally here is implement interim measures while we're waiting a regional and or provincial direction with that regard. So have sort of a 3-tier approach. One is a precautionary principle with women that are pregnant who aren't comfortable saying that if possible they should not perform, not care for suspected or confirmed positive COVID patients while we're awaiting interim measures. And I know our regional partners are doing the same. Sorry, while we're awaiting direct guidance. And I know our regional partners are doing the same. For those with underlying chronic medical conditions, we've said that's a conversation between their primary care physician, our occupational health services, and their supervising manager or division or department chief to see if accommodations are required. And finally, for those, and what we chose internally as the interim is over the age of 65, although others in our region have chosen 70, and we're just finalizing what that is, years of age, likewise, if possible, to avoid direct patient care of those with confirmed or suspected COVID infection.
Thank you. Peter, anything to add?
No, our approach is very similar to just what Linda just described. We haven't set an age limit yet, but certainly the pregnant, in inverted commas, condition, we have broken it up similarly into those with health issues related to pregnancy as opposed to just pregnancy itself. And so we're waiting for higher up direction as well, exactly as described.
Thank you. There's a comment with a question. Great to hear how your team was able to do changeover to virtually overnight. And as a comms person, this person would love to hear how you communicated that to all of the stakeholders.
So it's Lindy here because I mentioned that. So we haven't completed the changeover. Please don't think that we just turned it on and everyone was using it. We're doing about 35% of our visits that way now, and a lot of it is just switching over from telephone. So the communication was key. We had specific communication, and in fact, another one went out today to our care providers, initially about how they could do it on their own, and then if they were already hooked into the virtual provincial system, and then how to do it through our system. And so we've had targeted communication. We've also set up a virtual care page on our internal website so that people can quickly go to it to find out how to do it. We have an integrated electronic health record through Epic, which I know many other hospitals are now just starting with or have on board as well. And through that, we have a patient portal called MyChart. So we're able to send out to the families that are already connected through MyChart information about virtual care through that, and in other communication to families, doing it prior to the planned encounter through a telephone conversation with either the patient service clerk or the case manager, depending on the type of patient. But you know, my kudos to you as a communications person who asked the question, because you guys are really the stalwarts of us doing this, and both from a family perspective and also from a staff perspective. So I bow down to you. Thank you.
Thank you. There's a lot of bowing down to a lot of people during these, there's heroes emerging from everywhere. This commenter and question, Lindy referenced how quickly information is evolving. What communications channels are you using to keep your command center and also your broader staff and physicians up to speed?
Sorry, who was that directed to me as well?
Well, anyone can answer it, but the commenter referenced your comment about how quickly the information is evolving, and that you determined that you needed to send out the right information in the right amount at the right time to have timely information, but not too much.
Right.
And what channels were you using?
Yes, sure. So I can start, and then Nisha and Peter, please jump in. I'm sure it's different in BC for sure. So it is just that there's an overwhelming flood of information. We have unbelievably engaged and on top of it experts that are, I don't know how, filtering all the information so quickly, bringing it to the IMT, but we're also trying to make sure that we're not getting bogged down in the details, so that when things come forward to our incident command, they've come forward in the context of the new information, which is shared, but then with a recommendation about what to do with it, so that the right people are the ones that are sifting through the information. In terms of sending it out to the broader organization, to all the staff, we're using a daily communication via email from our CEO that's vetted by 4 senior leaders before it goes out every day. And also we're having a daily at noon virtual meeting of all the people that manage people in the organization. So our managers, our directors, our division chiefs, our department chiefs, and the executive team, to give them a brief update about what's going on, what are the key points for the day, so they can then filter it out through their own areas. I would say one challenge is from the medical staff side, all of the specialty and subspecialty organizations around the world, the Canadian Society of X, Y, Z, have all rapidly put out their own advice to the specialists and subspecialists that they support. And sometimes that's being done from a very narrow perspective, and sometimes they're being done more evidence-based, and other times they're more expert opinion. And I would say that has posed a challenge in terms of getting everyone on board to do the same thing in terms of PPE. And I can turn it over to Nisha to add some detail to that, but if in order to be safe for our patients and safe for the staff and medical staff, we all need to know what we're doing when, and that we're all doing the same thing. And that has been a little bit of a challenge. Nisha, I don't know if you have any other comments.
You know, I think where there has been uncertainty and where there have been where there has been a lot of discussion between organizations, because we do have staff who cross-cover, for example, our respiratory therapists, some of our emergency room physicians, and then people who have friends who work in either other adult hospitals nearby or pediatric hospitals further down the road. I have found that from an infection control perspective, we've had to be very tight with the evidence that we're working with and consistent in our approach to having evidence-informed practice, because that, again, sharing that kind of messaging with staff brings clarity in periods of uncertainty, as well as enables acceptance where we have changes in the recommendation based on new evidence. So we've sought to get we've tried to get regional clarity as well as consensus with our pediatric peer hospitals. So, I'm on emails every week, multiple times a week, with my medical IPAC physicians and teams, just so that we can work with our best level of evidence and have a similar approach, because it shouldn't matter where the child is being cared for, which province or which jurisdiction. We should have consistency in our approaches, and that's reassuring for staff as well, and reassuring for our senior leadership, knowing that we're working with the best level of evidence that we can, and not just being responsive to people's anxieties and epidemiology that may not exist in our region.
Thank you. This question could go to any of the three of you. What do you view our role as pediatric care providers in supporting our adult colleagues who may face overwhelming numbers in patients in the coming months? And have different organizations discussed or planned for this?
Well, I can start. I mean, we certainly discussed this amongst the different health authorities. The chairs of our EOCs have reached out. Our hospital has come up with an expanding plan on initially. Currently, the plan is taking the pediatric patients from all the other health authorities. We are a provincial resource, and there are other health authorities in BC that children attend their other local hospitals. So that's the first phase of this hospital, and then escalating up for different ages up to the low adult ages, late teens, low adult age. Our current age is 16 years and 364 days, but escalating up to, I think it's 20. From an ICU perspective, as mentioned earlier, we're willing to take adult patients in their 20s and or more if the surge is that demanding. And it'll be a case-by-case basis, obviously, with no comorbidities for the adult patients, but we'll do whatever we can, and the hospitals and the health authority is offered to do whatever we can to the other health authorities that are likely to be inundated by these the adult disease that we're facing here.
This is Lindy here. We're taking a very similar approach here. I would just support that working together with our regional partners, our adult providers, is really important in doing this. And I would have mentioned that's a key principle overall as well. We were thinking, the adult side here is already getting quite stressed, and they are going to be the ones overwhelmed. And so we are putting together a sort of package of what we think how we will best be able to help, flexing up age, certain procedures, trying to take the burden off from other hospitals that do see some children, etc., just like Peter was saying, and sort of presenting that at the regional table, rather than wait till the last minute to say, okay, now everybody's overwhelmed, what are we going to do? The other thing for us is looking at opening up a pediatric FRI clinic on site, again, to sort of take the burden from the more adult hospitals that would see a few children every now and then, etc.
Thank you. Another, screening healthcare workers prior to entering the building seems to have progressed to help us feel safer, and the commenter says still a ways to go, but are clinics and hospitals taking the same measures with patients and families entering the building?
Absolutely, at BC Children's.
Yeah, same here at GEO, and we've actually cut down significantly on. We have no visitors in the hospital now. We do not consider parents as visitors, but we have limited. Each child coming into the hospital can identify 2 parents that can potentially stay with them, and only one at the bedside at a time. And all of those individuals are screened and are not allowed in if they're symptomatic.
Thank you. What has been done in terms of ramping down ambulatory services in order to support inpatient units?
I can't speak too much to that because I'm not. I don't deal with those. But from my understanding of the Department of Pediatrics and Surgery is once again, as much as possible, they've gone remote if possible. Our cardiology team, which normally does a touring clinic around the province, that's been cancelled. So as much as possible, most of this is virtual as IMIT improves the access for the physicians with virtual programs so they can do that work.
We've also, for now, this is our 2nd week, and we've just made a decision to extend it through April. Really canceled all non-essential in-person visits. There's a bit of, deciding about what's essential and what's not. Those that can be deferred are being deferred. Those that can go virtual are going virtual. And we've set up a redeployment center for staff, so that staff that might not have as much to do as they would otherwise are available for redeployment. I would also ask that, given the provincial state of emergency that Ontario's declared, as of most others, and the direction for everyone to stay at home as much as possible, we've very quickly identified what proportion of our workforce can stay at home, but even if they're at home, available for redeployment to help, and so could be called back in to help in acute care areas.
Thank you. This question's directed to Dr. Skippen, but once he's answered, Lindy or Nisha, you may want to also weigh in. Just wondering if you've created a specific set of orders for pediatric patients presenting to the emergency department with suspected or confirmed COVID-19.
For doing what? So just, if any patient comes into the emerge with respiratory symptoms, they are placed in an isolation room, and then the screening by the emergency physicians is whether they're high risk or low risk. They will all get a swab if they need to be admitted. If they're not sick and they don't need to be admitted, they will be sent home. Is that what they're asking?
I think so, but what I'll do is ask that poster to clarify if that doesn't answer the question.
So similarly at CHEO, a patient who's identified as being symptomatic right now will get a throat swab in the emergency department, and if they require admission, then they will get a throat swab and an NP swab. And and there are specific orders that go along with that, with the collection of samples. So that's been standardized through our emergency department protocol.
Thank you. Question, does anyone have modeling for pediatric cases with 5D and 7D modeling for inpatient and PICU over the next 6 weeks?
I've seen that on our critical care listservs. There's a database called VPS that captures North American pediatric intensive care units, and it's been up and contributed to by currently over 100 PICUs in North America. And this morning when I checked, after a week's data entry, there were still only a total of 10 children in all of North America in the 100 units voluntarily donating their data to pediatric intensive care unit.
And that was VPS?
It's called VPS.
Yes.
And at our chief of intensive care sits on a provincial committee for ICU for patients requiring critical care, and so we've taken more of a we have a more regional approach, kind of speaking to your previous question around regional preparedness and providing support. So while we haven't modeled pediatric data, it seems pretty favorable, with only about 0.2% requiring intensive care. And so we've been working to prepare our ICU to receive young adults who don't have COVID-19, but potentially decanting from our adult sites, so long as we have the capacity met for our pediatric patients.
There's a comment here in response that says, thank you. The person had seen the VPS sites, but doesn't know the total confirmed cases over the VPS sites. And another comment suggested there are 19 as of now.
There might be, but still 19 in the grand scheme of North America and 100 units is still a small number. I haven't seen, there was a modeling tool put up on Alyssa this morning. I did not look at it. I haven't seen anything coming out of Canada.
Thank you. How are you managing the anxiety of frontline providers?
Daily check-ins.
Go ahead, Peter.
I just said daily check-ins. Basically, it needs to be real time. If there's any concerns, they need to be addressed at the time, and give them honest answers.
Yeah. So, no joke. I think many groups in our organization have discovered infection prevention and control in the last 2 weeks, and far from being impatient about the need to roll things out, I have taken the time to myself and the IPAC and our small but mighty IPAC team and clinical care working group have taken the time to work through the anxieties, which reflect, I think, an uncertainty in our guidance documents. For example, about what is an aerosol generating medical procedure. It reflects mixed reports in the literature, and sharing so one strategy that we have alongside the daily check-ins are meeting with clinical groups where their associations are informing them of the need to have N95 respirators where it may not be indicated, sharing evidence, discussing the specific concerns and coming to a consensus. I think those are time intensive early on, but I think we reap the benefits of that collaboration down the road. So, that's how we've been managing anxieties, through communication.
Can I just add to what Nisha said? It's that initial communication, it's debriefing, and then it's practicing what they have to do through simulation or real things. And then at a higher level, we've been offering virtual town halls with over 600 people calling in as sort of Q&As around specific issues. We had one the other day that Nisha did a great job of with regards to PPE. And those check-ins through reminding, we've sent lots of reminders out to the leaders and managers about wellness and anxiety check-ins with their staff as well. But it is about the honest information being provided in a way that's accessible to everyone and having them practice what they need to do.
Thank you. There are two sort of related comments. How will you meet the service needs if the availability of healthcare workers is reduced? And the second part is what's your plan to catch up on the delayed procedures once this crisis is over and under control?
This is Lindy here. With regards to the latter part of that, I was reflecting back on our lessons learned after H1N1, and one thing that we did really poorly was the ramp up afterwards. And one of our lessons learned was you need to give some thought to it. You can't just all of a sudden turn it on, back on and figure out the backlog. So it's obviously too early to be thinking of that now, because I think we'll be in a ramp down mode for quite some time, but it needs to be thoughtful and it needs to be planned and it needs to be staged. That's about the ramp up part of the question. And then with regards to the staff, we have so many staff that are away due to self-isolation right now. It's interesting to me how many people still chose to travel. And our March break happened just at the time when travel was not recommended. We had sent something out just prior to our March break saying that all work-related travel was on hold and that we discouraged personal travel. But we are still seeing either staff that are symptomatic or self-isolating for post-travel reasons. And so one of our ways around that was with the redeployment center. And then in our scaling back of non-essential services, we've managed to free up some staff to help.
Thank you. There's one more question. Do you have any documentation that spells out the role of families in the command centers? And the commenter applauded you for having families at that in those roles, but do you have anything that describes it?
So no, not for this particular. We had just redone our family advisor onboarding processes, and each of the 3 that have come on and that we've had 3 so they can spell each other off. Each of the 3 are not new advisors. They're people that have been in a family partnership role with us for some time, and so they're seasoned. We do need to develop a formal document, and it is on the list to do, and we will do that. But they're all being onboarded and supported by our patient engagement, our child, youth, and family engagement team, and having opportunity to brief and debrief with them every day, but definitely on our to-do list.
Thank you. And one last question. Are any of your staff currently being seconded to work at adult centers?
From our perspective of BC Children, they've been promised that won't happen. They could be reallocated within the organisation, and they're pleased about that.
So we have not redeployed anyone to the adult side. At this time, we have not promised that they won't be redeployed, but that's part of what we're working on, is to share with the adult system what it is we can do to help them by keeping people here as a first start. Peter, with your intensive care lens on, I think it's ICUs and maybe emergency doctors and anesthetists that might be the group that are the skills that are most sought after. So it's interesting that you haven't, you've promised they won't be going.
I want to thank you all. That's the end of the questions. I want to thank you so much for your time. This has been a fabulous session. And as another commenter just posted, that this transparency in such stressful times is truly appreciated. Thank you so much.
Yeah, thank you.
Thank you.
Thanks, everyone.